Hi, good evening, ladies and gentlemen. Please allow me to apologize for the late start. We are starting 1 minute behind time. I am Dr. Aysha Bianca Edwards-Remy. I'm the head of clinical services at AAR Hospital, and it is my pleasure to moderate today's webinar. I will be taking off my camera as I go through introducing our speakers and giving you a bit of housekeeping. So good evening, Karibuni Sana. So this evening's webinar is on chronic back pain. Our presenters are Dr. Kimani, an orthopedic spine surgeon, and Dr. Wamutitu, an orthopedic and trauma surgeon. So I'll just tell you about both presenters as they are doing one presentation and we'll be taking questions at the end of the presentation. Do feel free to type your questions in the question and answer section or in the chat. You can also ask questions by using any of the online platform at AAR Hospital, hashtag chronic back pain. That is at AAR Hospital, hashtag chronic back pain. Dr. Wamutitu Maina is an orthopedic and trauma surgeon at Kenyatta National Hospital and also currently serves as the head of department of the accident and emergency at KNH. Prior to this, he worked at AIC Lytton Mission Hospital in Kericho County, where he helped set up a vibrant orthopedic service. Dr. Wamutitu undertook his undergrad training at the University of Nairobi and obtained his postgraduate at the same institution. He is a fellow of the College of Surgeons of East, Central, and Southern Africa, and he has a special interest in spine surgery and served as a national faculty of the AO Spine. So welcome, Dr. Wamutitu. Because you guys are sharing a presentation, I will also introduce Dr. Kimani at this time. Dr. Moses Mwangi Kimani is an orthopedic surgeon and lecturer in the Department of Orthopedics at Kenyatta University. He is also affiliated with the Nairobi Spine and Orthopedic Center. He is an experienced orthopedic spine surgeon with a demonstrated history of working in the higher education industry, skilled in spine surgery, orthopedics, clinical research, and teaching. He has strong healthcare service professionalism with an AO spine fellowship focused in spine surgery, an emphasis on trauma, deformity, degenerative, and infection from University of Cape Town. Welcome, Dr. Kimani and Dr. Wamutitu.
Thank you, Dr. Aysha.
Good evening, Dr. Ari. As soon as you're ready to start, you can proceed.
Okay. I think I'm ready to start. I'm not sure how to go to the slideshow. All right. So I think today's discussion is mostly about chronic back pain. And so we'll start with the basic definition of what low back pain is. Low back pain is pain in the area, the posterior aspect of the body from just where the ribs end to the lower gluteal folds. So it also includes the gluteal folds. Basically, this is an anatomy showing how the spine looks like. Okay, so in the spine has numerous structures, from bony structures, ligamentous structures, of course, neural structures, the nerves, the spinal cord. We also have joints. We have muscles and all that, and all this can be part of what we call the pain generators in the spine. For example, you could have a problem with the bony anatomy, and that could cause pain. Could have problem with the joints, like we see in arthritis and other conditions like that, and that can cause pain. So really, the spine is a structure that's made up of so many things, and any of those can cause pain. And sometimes that brings a challenge, especially to clinicians, in terms of trying to identify where a particular patient's pain is coming from. Is the slideshow working?
Dr. Wamutitu, just give me 1 second. Let me stop sharing for a minute. I forgot that today we are joined by guys also on Facebook Live, and therefore I need to go live. So Dr. Wamutitu, do you mind going back a few minutes to your first slide?
No problem.
Thank you so much. To the participants on the call, do accept my sincere apologies. Whenever you're ready, Doc.
All right, thank you, Dr. Aysha, and welcome everyone. We'll start again. We'd only done 2 slides, so it's okay. We wanted to start with a definition of what low back pain is. So low back pain is pain in the area of the on the back, the posterior aspect of the body, from the lower margin of the 12th rib. That's the lower region where you can feel your rib, to just below the gluteal, to the gluteal fold, just below the buttocks. So an anatomy of the spine and what we call pain generators. So the spine is made up of numerous structures. Okay, we have bony structures, there are ligaments, there are joints in the spine, there are nerves, there's a spinal cord, okay, there's the disc, okay, and all these are what can cause pain in a patient. So these are what we call pain generators. So it's important to understand that sometimes it may not be possible to identify what exactly is causing pain in a particular patient. Okay, so that's usually one of the challenges that faces clinicians in terms of explaining or trying to explain to a patient why they have pain. And sometimes maybe you've done an X-ray and you tell them the X-ray is okay, but they still have pain. So basically, it's because the back has numerous structures, and any of which can be a source of pain. Prevalence of back pain or pain in the spine. So generally, 80% of us will have low back pain at any point, at least at one point in our lives. I'm sure most of us have had some pain, some back pain, either because you sat for too long, you were doing some chores that were a bit heavy. So we've all experienced back pain, and generally in a lifetime prevalence of back pain is about 80 to 90% for all of us. Now, when you go to other regions of the back, like for example, neck pain, the lifetime prevalence is a bit lower. You can see up to about 70%. Thoracic pain, that's pain behind your chest, that's about 30%. But low back pain overall is the most common, which most of us will at one point or the other seek medical attention for. So some of the risk factors for back pain, first of all, is a prior history of back pain. So if you've had an acute episode of back pain, it's estimated that the chances of you having another episode of back pain is more than 50%. So a prior history of back pain generally means you more likely to have back pain at some point. Of course, as you age, various things are happening. There are degenerative things that are happening to your back, so you're more likely to have back pain. Also, lifestyle issues like smoking, alcohol intake are risk factors for back pain. Also, back pain is has some association in terms of gender and people who are suffering from psychological issues like depression. Dr. Aysha, sorry, I can't see the presentation on my end. Oh, thank you. It's back up. All right. So some of the other risk factors for back pain, the occupational risk factors, of course, manual laborers, people who are involved in activities or occupations that involve a lot of twisting and bending, like gymnasts, or people who are involved in whole body vibration, like people in construction and all that. Also, there's like I said, psychosocial and psychological aspects may also play a big role in terms of back pain. So patients who are satisfied at their occupation, patients who lack social support at the workplace, or even those who are under a lot of demands and stress at their work environments are more likely to present with back pain. So some of the tips to avoid back pain, which I know is something most people who join the presentation are very keen to know. One of the things is that you must remain active. Okay, must remain active to avoid obesity. Okay, so excess weight on the back results on spraining and early breakdown of discs and cartilage. So early degenerative changes may happen because of obesity. Overuse. So despite us saying that you need to be active, we also there's also a limit. There's a caveat to that. Overuse or excessive activity or carrying excessively heavy loads can lead to degenerative changes in the back and causing back pain. Overdoing any exercises, especially after a long absence, can cause some back pain. So we generally advise that patients start slowly, especially if you're not used to an activity, start slowly and progress until to the degree that you feel comfortable with. Also, certain avoidance of high risk activities. Okay, so I know we've mentioned football and basketball, but generally, to a certain extent, overdoing of any of these activities can cause back pain. And of course, observing good postural habits. This is very important, especially for people in occupations that require them to either be seated or standing for long periods. Good posture is paramount to avoiding low back pain. Just a few examples. So this is a standing posture, okay? So ideally, standing posture, your lower back is in neutral positions and your head should be right over your shoulders. So not slouching forwards because this creates an imbalance and can cause back pain, either in low back pain or in the thoracic region. Sitting. So I know I'm sure we'll get a question on whether to use an orthopedic seat or not. My advice has always been the posture you use is more important than the seat you have. So you can have a very ordinary seat, but so long as your posture on it is good, then you will definitely not suffer from low back pain. So ideally, you should have a seat where your feet are able to reach the floor. Okay, so you sit back in the chair in neutral and mostly alternate with standing. So usually 2 hours, then you can stand for about 5 minutes. This is the kind of posture that you should have when you're lifting, especially when you're lifting very heavy objects. And heavy means probably something that is heavier than your body weight. You should hold your object, you should squat, hold the object close to your body and lift with your legs, and not bend forwards and try and lift with your back. And also, if you're lifting something heavy, maybe it's also important to try and get some help as opposed to doing it alone. Sleeping position. So my advice when clients ask me, should I get an orthopedic mattress? My advice is that's not as important as having the right posture when you're sleeping. Okay, so avoid using too many pillows. Okay, you can use maybe one single pillow. You need a firm mattress and the correct posture. Thank you. So when should a patient go to hospital when they have back pain? First of all, I'd like to mention that most back pain, like we've seen, 80% of us will suffer from back pain at some point. So most back pain has no serious cause. Okay, so no need to worry when you have back pain. Okay, most important is to know when to see a doctor. Okay, so if you experience very severe pain that probably you've never experienced before, or you have pain not very severe but it has lasted several weeks despite the usual things we do when you have pain, maybe take some paracetamol or rest and things like that, or you have pain that is preventing you from your daily activities. So if you find that you have back pain that has stopped you from, say, driving or going to work, then that probably means it's serious enough for you to at least seek medical attention and see what the problem could be. So when you go to hospital, this is basically what goes in the mind of any medical practitioner. Is the pain acute or is it chronic? Acute means, is it of sudden onset? Chronic would mean pain that has been there for quite some time. Okay, and this generally just helps helps the clinician in trying to decipher what exactly could be the source of pain. The other thing that a clinician must do is exclude non-serious causes of pain. Okay, like we said, most back pain has no serious etiology, but back pain also can mean that there is something, can be a symptom of an underlying condition. So any clinician must rule out, must exclude any non-serious causes of back pain. Okay, and then generally from the rapport you create with the client and talking to them, you're able to do a brief psychological and psychosocial assessment of the patient. So these are the serious, we call them the red flags, the symptoms or the findings that that the clinician will lead the clinician to thinking that you indeed have a serious cause to your back pain. So if there is history of trauma means if there was a fall, you were in a road accident, whether at that point or earlier on, okay. If you've experienced weight loss in the recent past, if you have neurological symptoms, that means you have pain that's traveling down your legs, you're having numbness, or you're having difficulty in walking because of weakness in the legs. Generally, if you're above 50, that's also a red flag to an acute onset of back pain. If you're having back pain together with fever, if you're having back pain and you're an intravenous drug user, or you're having back pain and you're on steroids for whatever reason. Some patients are on steroids for asthma or for other autoimmune conditions. Or if you have back pain while on treatment for cancer or a history of cancer, maybe you've been finished treatment for cancer, but you now present with back pain. That is generally a red flag, and that means that the clinician will need to do further investigation to find out to dig deeper into the cause of your back pain. And this is a mnemonic that we used to use when we were in school, tuna fish, for all these red flags. So after the clinician has taken history, they'll go ahead and do a physical examination. Okay, so when the physical examination starts from when the patient is walking into the room, for patients who are able to walk during transfers, you're able to note any gait abnormalities, any ataxia, or obvious pain, even from the facial expressions of the patient. Then the clinician will perform a meticulous neurological examination, especially if the patient has neurological symptoms. Then they will do what we call provocative testing. These are provocative testing are just tests that try and provoke symptoms. So there's what you have femoral, a straight leg raise or femoral stretch test. The neurological assessment, mostly the effect of position on symptoms, and any relieving or exacerbating factors should be noted by the clinician at that point. Now, depending on the findings from the history and the physical examination, the clinician may decide to order mostly imaging investigations, but sometimes they may also decide to order blood investigations. Like we've seen things like when you have back pain and fever, which is a red flag, the clinician will most likely order some blood investigations to find out why you have those true symptoms. Imaging, we have X-rays, we have CT scans, and we have MRIs. So there are various indications for each of these imaging modalities. Okay, so for example, X-rays and CT scans are mostly used to look at bony issues. Okay, so if there is a history of trauma, for example, you may have to order an X-ray first before you order for an MRI. An MRI is mostly used when you're suspecting either degenerative conditions, okay, or you have things like infection, cancer, things like that. So mostly for soft tissue and degenerative conditions is when you need to order an MRI. And treatment, various things in treatment, from pharmacological to physical measures, psychological, and there are invasive techniques that are used in treatment. So pharmacological is basically most of the patients land in the first two classes, either pharmacological or physical treatment, or both. That's because most back pain has no serious etiology. So pharmacologic treatment, most of the drugs, most times, what we use are called NSAIDs. These are non-steroidal anti-inflammatory medication because of their anti-inflammatory and analgesic properties. Okay, most of the back pain, there is both you want to reduce pain and you want to reduce inflammation. NSAIDs are also known to be antipyretic. That's if in case you have a fever, they will also help in reducing the fever. And because of the large muscle aspect in the back, muscle relaxants are also some of the drugs that we use in trying to treat back pain. Okay, opioids are a class of drugs that are widely used, especially in the West. We probably don't use it so much for mild to moderate back pain, but they also have a place, especially in acute severe back pain. Opioids do play a role in terms of reducing. Of course, any clinician who needs to consider the risk factors and the side effects of all the medications that they're giving. So like NSAIDs are probably not the best option when you're having a patient who also has things like gastritis or asthma. Okay, opioids also probably need to, the clinician will need to consider the risk of dependence and whether that how severe the back pain is, if that warrants the use of opioids in that particular patient. Physical measures, these are physiotherapy, where there are various things that are done in physiotherapy. These are just a few of them. Massage therapy, there's posture training, muscle strengthening, especially for low back pain, core strengthening. There's nerve stimulation, there's ultrasound therapy. There are various things that are done by physiotherapists to help in reducing the pain from low back pain. Okay, so and also behavioral therapy is part of what physiotherapists are able to do to help in reducing back pain. Some of the invasive procedures, like epidural steroid injections, depending, of course, on the indication. Epidural steroid injections are basically steroids that are injected around the nerve. They help in reducing inflammation that may be causing back pain. More recently, the other newer interventions like percutaneous laser disc decompression, which basically helps in decompressing or relieving back pain that is secondary to a prolapsed intervertebral disc. Percutaneous nucleolysis also say almost a similar procedure that helps in reducing back pain from a prolapsed disc, and same thing as radiofrequency nucleoplasty or nucleotomy. They are all newer interventions with very specific indications for reducing back pain. Then lastly, and it's in capital letters, surgical interventions. There are various surgical options, although most patients, to be honest, most patients who have back pain rarely require that any surgical intervention. But of course, a few will need surgical intervention, and this is also available. I won't go into the techniques and all that. I'd like to say that all these invasive or minimally invasive, like epidural steroid injections, laser disc decompression, all these are available even at the AAR hospital. Some of the things that really raise a lot of debate in terms of treatment for low back pain, things like chiropractic, yoga, acupuncture, homeopathy. Sorry. I'd like to say, like, for example, in yoga is exercise, and like we said, one of the things that you need to do to reduce back pain is to remain active. Okay, yoga, there are a lot of stretches, there are a lot of exercises that you do. So long as you're active, it will help reduce back pain. Chiropractic is also a different. There's a science to it. As a doctor myself, I may not be very well versed with what chiropractors do, but I can't say that I've seen patients who will swear by chiropractors. So, I mean, my advice is usually, if you feel it makes you better, why you go for it. So, in conclusion, there is no silver bullet in treatment of back pain. Okay, so there's no one size fits all. So, for example, one patient may go to a chiropractor and they're okay, they get better. Another patient will go and they'll get worse. There are patients who will go and be on physiotherapy and they're not seeing any difference. So there is no silver bullet. Every patient is different and every back pain is different. Okay. Most important thing is that I'd like to emphasize that most back pain has no serious etiology. So there's no reason to panic or be overly alarmed when you have low back pain. Okay. When you see a clinician, the most important thing they need to do is exclude non-serious causes. Okay. And then as a clinician, all clinicians need to be aware of the side effects of the medication that they are giving, and they should counsel all patients appropriately and make the treatment to the patient. Because like I said, there is no silver bullet back pain. Thank you.
Thank you very much, Dr. Wamutitu. We'll now open up to the questions from the audience. We seem to have had a bit of technical difficulty this afternoon. However, this is recorded by a Zoom cloud and will be shared on Facebook. So you can actually review the presentation on Facebook. It just will not be live. So Dr. Wamutitu and Dr. Kimani, the first question or comment is, once operated, can one really recover completely, or does the pain just recur later, especially with the scarring?
Thank you, Dr. Aysha, for the question. Yes, you can recover completely from a spine operation. And actually, most of the patients do very well after a spine operation. There could be other causes of a recurrence of the pain, but might not be associated with the original condition that you had.
Another question from the participants, kindly explain how alcohol and smoking is related to lower back pain.
That's an excellent question. In the beginning, Dr. Wamutitu talked about the risk factors for low back pain. And one of the biggest risk factors is smoking. It's associated with 5 to 10 times increased risk of having low back pain compared to the rest of the population. So as we know, smoking is associated with many other conditions, and if you can, please avoid. Alcohol might not have a direct association with low back pain, but remember, there's increased incidences of trauma following a binge of alcohol, or you can fall, you can sleep badly. So alcohol is mainly associated with low back pain following trauma, but not directly.
The next question is, would you recommend any chiropractor in Nairobi?
Well, we practice the mainstream medicine, but I know there are very many good chiropractors around. We say that we do not have 100% answers to all the causes of low back pain. So if you do visit a chiropractor and you think you're doing well, we highly encourage you to continue with them, because I know even up to now, if we had all the answers to the cause of back pain, we'd be able to treat all back pain very well. So there are many chiropractors around. Maybe you should have one in AAR. What do you think?
Thank you for the suggestion, Dr. Kimani.
Yeah.
I'm sorry, Dr. Wamutitu, we did not hear you.
No, I was saying probably something worth considering, having a chiropractor.
Thank you.
Maybe in our next session, so that we can interact and see.
So I will ask one question, then I notice Dr. Okumu has raised his hand, so we'll invite him to unmute his mic and make his comment, question, or feedback. So the question that I'll ask before Dr. Okumu is, what options or activities for someone who has back pain, chronic back pain, and would like to use the gym? So I'll repeat the question. What are the options or activities for someone who has chronic back pain and would wish to use the gym?
I think, as we earlier alluded to, there are many causes of chronic low back pain. And when the pain is persistent for long, the ideal thing is first visit your physician or doctor. Following the visit, we'll have to exclude serious causes. Once we have excluded serious causes, we tailor-made a program that will enable you go back to your gym activities slowly. Remember, we said try to do it. Try to take it slowly as you go back to the gym.
Thank you, Dr. Okumu. You can unmute your mic.
There's a question from Dr. Aysha. There's a question from Amos Mungai, where he asks, we should comment on the use of lumbar corset belts in prevention of low back pain.
Hello, can you hear me?
Yes, you can.
Yes, Dr. Kumu, we can hear you. Just allow Dr. Kimani to answer Amos's question, then we move to you. So please proceed, Dr. Kimani.
The long-term use of lumbar corsets is not encouraged because prolonged use is associated with even increased incidence of and intensity and duration of low back pain. So we, at the moment, recommendation is to use a lumbar corset in the acute setting, preferably for less than 2 weeks, because it's been shown for sure if you use a lumbar corset for more than 3 months, you tend not to get wind of it. And once you stop using it, the pain actually gets worse. So the current recommendation is do not use your lumbar corsets for long. Just try to use it in the acute severe episode. And as you start getting better, throw it away.
Thank you very much, Doc. Dr. Okumu?
Okay, I think although I would agree with my colleagues that some patients do see benefits from visiting the chiropractor, I would like to stress the other aspect we are talking about, that we are not entirely conversant with the methods that chiropractors actually use to alleviate back pain. And they are trained, there may be some science to their work, but it is important to qualify that statement and say that when you go to a chiropractor, it is a bit at your own risk. And there are patients who actually get worse. So please go with the understanding that not all visits to the chiropractor will be beneficial. And I honestly don't know if as orthopedic surgeons we can, wholeheartedly recommend chiropractors until probably we understand a little bit more about the way they work. And so that engagement that we're encouraging might be the way to go to learn a little bit more about their practice. But as a qualifier to recommending a chiropractor, I would say there's a bit of a risk.
Thank you, Dr. Okumu, for that feedback. Dr. Kimani, do you want to comment on that as we get ready for the next feedback from our Q&A?
Well, I totally agree with Dr. Okumu. We do practice mainstream medicine or the conventional medicine. We know there are regions where even yoga is big, acupuncture is big, and even chiropractor practice is very big. Yes, we do not understand much of what they do, yet we have patients who come and say, oh, I visited a chiropractor and I got better. Remember, what is the natural history of low back pain? Majority of us get better, whether you're treated or not. And the natural history is that for non-specific back pain, basically the back pain that does not have a cause, we know that in about 4 to 6 weeks time, once from the onset of the pain, you do get better. So in that time when we are getting better, we give you the analgesics. You tend to get to a physiotherapist, and 80% of us will get better whether we are treated or not. So that's natural history. So you can visit a chiropractor and you think he's done a marvelous job, but yet you are on the mend by the time you are going to visit the guy.
Thank you very much, Doc. So there's a feedback here. Nicotine deprives disc cells of nutrients, hence they are not able to absorb nutrients from the bloodstream. So I think that was in response to the smoking and alcohol question that was asked. As we continue along with the questions, the next question is, New onset paresthesia post-physiotherapy in a young adult male with chronic lower back pain. MRI had shown L4, L5, L5S1 disc herniation. Next mode of action.
Yeah. Okay. So a lumbar disc prolapse is one of the common causes of low back pain, and there are different ways we manage them. First, we have to rule out any acute indications for urgent intervention. If you do get blood and bowel dysfunction, these are the patients who would like to quickly do surgery and decompress them. There are some of these guys who have lumbar disc prolapse and they're in so much severe pain, intractable, not responsive to the physiotherapy and the analgesics. We also recommend maybe early intervention because they do very well with surgery. But the majority of patients with disc prolapse, they also get better. 70%, 7 out of 10 patients who are diagnosed with disc prolapse, they will get better over time. And the majority will get better over 6 weeks to 12 weeks. So in that period, we just manage their symptoms. We encourage them to be active, and we reassure them that they're going to get better. So now if it's really persistent, as symptoms go on for more than 3 to 6 months, we now advise you that you can benefit from invasive intervention, whether it is endoscopic or a microdiscectomy, because what we want is you to have pain relief. The pain relief can come non-operatively, or it can come operatively. When it comes operatively, it's instant. You have pain today, and tomorrow you don't have pain. Most of the time, it goes on very well. If you treat it non-operatively, we know that over a few months to 1 to 2 years, your pain intensity is almost the same as the one who was operated on. So the main advantage of surgery in disc prolapse is that you have instant pain relief.
Thanks, Doc. Next question. I'm so sorry. Doc, were you still giving, did I interrupt?
No, Dr. Aysha, you can go ahead.
Okay. This person asked 2 questions, so we'll do question 1 and then we'll come back to question 2. So question 1, how frequently should one turn over their mattress or change the mattress altogether?
Dr. Wamutitu is very, very eager to answer that question.
Sure, Doc.
Wow. First, I think I would like to say what the real reason to turning the mattress is if the idea is to relieve or prevent back pain, then there is no real guideline or firm answer that I can say, 3 months, 6 months. It really depends on how fast your mattress is wearing out. Like I said, most times you actually just need a firm mattress. So if the mattress, that side of the mattress is still firm, then it's okay. If it's not, then maybe it's time to change the mattress or to flip it over. I don't know if flipping it over would work better than changing it. Honestly, there is no firm answer for that, but flip your mattress once you feel that side is not firm enough.
Okay. Thanks, Doc. The second part of the question, relation to back pain after spinal anesthesia or epidurals?
Well, there's no direct relation to back pain after spinal anesthesia or epidural. That should be the summary first. But we know sometimes when we are giving this medication directly or near the spine, sometimes in a very rare circumstances, you can have some complications. One, you can have a low-grade infection that comes on in less than 1%. And also, you might have what we call dural puncture, where the CSF you develop complications from the dural puncture, or like some headaches, some bit of neck stiffness, but these are short-lived and they tend to go away. So I know this is a big question and a big discussion, especially for patients who undergo surgery under spinal anesthesia. just remember that the rates of low back pain after that is very, very negligible.
Thanks, Doc. The next question is accompanied by a feedback. So the person says, that was an excellent and highly enlightening presentation. Is heat therapy good for lower back pain?
I can see, thanks, Yvonne. Heat therapy is actually one of the modalities that we use in physiotherapy. And when you look at the different trials that have been done, it's one of the modalities that is recommended in acute low back pain. So when you go for physiotherapy, I know one of the main modalities that they put for you hot packs. The other one that which is highly recommended is the massage part of the physiotherapy. So all these have been shown to have a good, in terms of outcomes, better when it's included in physiotherapy. Yeah, but remember, when it's been done, they should also avoid burning you, because that's one of the side effects of using heat during physiotherapy.
Next question.
Okay.
Sorry. The next question is, can platelet-rich plasma injections be considered for lower back pain treatment?
Yes, maybe I probably forgot to mention, it's one of the newer modalities that have been used in treatment of low back pain, and I know it's available at AAR hospital. Platelet-rich plasma injections help in mostly reducing the inflammation. So if your back pain, especially degenerative back pain or acute back pain due to a prolapsed disc, causing a lot of inflammation, PRP injections can be used. However, the evidence is really out there. Some patients will get better, some will not. So, but because the risks are very low, the side effects are almost negligible. It's something that's worth trying.
So I think at this point in time, we've come to the end of the questions. So I want to hand it over first to Dr. Kimani, followed by Dr. Wamutitu. Any closing advice that you'd like to give to colleagues, patients, relatives, caretakers who are on this call and who will hear this presentation on various social media platforms and may have other questions around chronic back pain? Dr. Wamutitu.
All right, I think for me, the take-home message for them would be back pain is very common, okay? Almost all of us will experience back pain at some point in our lives, so there's no reason to worry, okay? Most back pain, more than 80% of the back pain has no serious etiology, meaning there's no serious reason to why you're experiencing back pain. Of course, there's sometimes that you will need to seek medical attention, and which would be wise, especially if the back pain is very severe or it has lasted several weeks. But there is no reason to fear back pain. The treatment is available from physiotherapy, medication. All these newer modalities of treatment are all available and with us. So my take-home message is let's not be afraid of back pain, and let's seek medical attention when we experience back pain.
Thank you, Dr. Kimani.
My take-home message is just like for Dr. Maina, that when you're in doubt, please visit a physician who will assess you properly, take a history, examine you, and why he's doing that is just to rule out the serious causes of back pain. After that one has been ruled out, you can be rest assured that you're going to get well.
Thanks, Dr. Kimani. Allow us to break protocol a bit. There's one late question that came in. I want to throw that question to you before we wrap. The question is there a correlation between the use of pillow and back pain?
There's no direct correlation. Some people cannot sleep without a pillow. And if they do that, they get a lot of neck pain. Others would the first thing that they do is throw away the pillow from the bed. So it just depends on your sleeping habits. So if you use a pillow, or if your first time to use a pillow and you get neck pain, and most of the time it's neck pain and upper back pain. Try to get a pillow that's comfortable for you. But other than that, there's no direct correlation between the use of a pillow and
Thank you, Dr. Kimani. As we wrap up our weekly webinar series, in the month of February, we will be looking at orthopedics. We do have other breakout webinars on the 14th and 15th of the month, which is next week, Monday and Tuesday. Of significance, our next webinar within this series on the 17th will be common pediatric orthopedic conditions. So we will also be sharing that on our social media handles. So thank you everyone for joining. Please join us at our orthopedic screening camp, which happens at AAR Hospital along Kiambu Road on the 24th to 26th of February. You will meet orthopedic surgeons like Dr. Wamutitu, Dr. Kimani, and even Dr. Okumu, who was with us last week. So thank you everyone. CPD points will be available within the next 72 hours. Do have a good evening, and we do look forward to seeing you on our next webinar.
Thank you, Dr. Aysha.